The next video that I want to show you and go through is chapter 23, so drugs for angina, MI, and CVA. MI stands for myocardial infarction. This occurs when there's a blockage, usually from a blood clot, in a coronary artery of the heart, and it's there long enough that it causes cell death and cellular necrosis to the myocardium distal to that blockage. CVA stands for cerebral vascular accident. The type of stroke, which means stroke, the type of stroke that I'm going to be talking about in chapter 23 is ischemic stroke. So I'm not talking about when there's an aneurysm that ruptures, causing bleeding in the brain, which is hemorrhagic stroke. For this chapter, we're talking about ischemic stroke again, so there's a blood clot or some type of embolism that's causing a blockage in the brain, and then there's lack of blood supply and oxygen to the area distal to that blockage, which causes an area of the brain to die. What usually occurs in the arteries over time is a buildup of plaque, which is called atherosclerosis. The problem occurs is when a thrombus comes along, and it could partially occlude the lumen, so that could be causing some pain because there's less oxygen and blood flow going to that area distal to this partial occlusion. But the major problem occurs when a thrombus comes along and sticks to the plaque, and it completely occludes the lumen, so there's no blood flow getting to that area distal to this blockage. When we talk about stable angina, so angina means chest pain. There can be stable angina and unstable angina. So as the name indicates, stable means that it's stable, predictable, it's reversible. But again, sometimes we don't know if stable angina is in fact a heart attack, that it's just starting. So the symptoms are very similar to a heart attack, but again, it can be reversible. With a heart attack, we cannot reverse the cellular death that occurs. For angina, it's acute chest pain caused by insufficient oxygen reaching the myocardium. The signs and symptoms are steady, intense pain, sometimes crushing, constricting in substernal region, typically radiates to the left shoulder, arm, thoracic region, or up to the jaw. There's a feeling of fear, panic, impending death, pallor, dyspnea, diaphoresis, tachycardia, and hypertension. And I've unfortunately seen a lot of people experiencing a heart attack, and these are really classic symptoms. These are actually how people present when they're experiencing a heart attack. But again, we have to differentiate. Are they having their stable angina, or are they actually having a heart attack? This is just a nice picture from another textbook indicating the areas where people usually experience angina. With stable angina, so the pain is usually precipitated by physical exertion or emotional excitement. So what's happening is that they're taxing their heart, they're increasing the workload of their heart. The heart can't keep up because they already have some kind of cardiac condition, so there's less oxygen being supplied to the heart muscle, and then they feel this pain. But if they rest, then it should resolve. Or if they decrease their stress or emotional excitement, then the chest pain should subside. So if they do that, it should resolve within about 10 to 15 minutes. Stable angina, these chest pain episodes are usually short in duration. And usually the person can tell you, yep, this is how my chest pain normally feels. It's in the same location. It feels the same way, the same intensity. I have the same kind of other symptoms like diaphoresis. But it's very different from an MI because it rarely leads to a fatal outcome, which can occur with an MI because that tissue is actually dying. So the goals for pharmacotherapy of angina are to slow the heart rate, to dilate the veins, and when we do that, that reduces preload. We want the heart to contract with less force, so that's reducing the contractility. And we want to dilate the arterioles to lower blood pressure, thus giving the heart less resistance when injecting blood into its chambers, which is referring to afterload. So if you are unclear of why preload is only in relation to veins and why afterload is only in relation to arterioles, then we need to review how the blood flows through the heart. So what happens is that the deoxygenated blood from the body enters the right side of the heart through the venous system. So the superior and inferior vena cava enters the right atrium into the right ventricle and then is pumped to the lungs. So this is where the blood gets oxygen from the lungs and loses its carbon dioxide. The blood then returns to the left side of the heart from the lungs, entering the left atria into the left ventricle. Then it is pumped via the aorta, which is the largest artery in the body, to the rest of the body to provide nutrients and oxygen to the body's tissues. So that's where we get the aorta is where afterload occurs, and the vena cava is where preload occurs. Again, this is a slide that I like to show because it's nice and simple. Cardiac output equals heart rate times stroke volume. Stroke volume is affected by preload, afterload, and contractility. The drug classes I'm going to review now are organic nitrates, beta blockers again, calcium channel blockers again, and thrombolytics. We are going to be focusing this talk on nitroglycerin. I've already reviewed the beta blocker metoprolol and the calcium channel blocker nifedipine. So nitrates, they're potent vasodilators. They relax arterial and venous smooth muscle. They decrease the cardiac workload of the heart, and they decrease the myocardial oxygen demand. So the goal is to alleviate chest pain, and usually it is if it's stable angina. The prototype drug I want to review with you is nitroglycerin or nitrostat. It's a very common nitrate that you will run into and administer to your clients. So it's a vasodilator. It relaxes both the arterial and venous smooth muscle, so it's affecting both preload and afterload. It's used for the treatment and prevention of angina. Again, one of the main adverse effects is hypotension because it's causing mass vasodilation. It can also cause a headache. Can you think of a reason why a nitrate could cause a headache? So what's happening if the arteries and veins of the body are being dilated? So what happens in the head is that more blood is being delivered to the brain, which increases pressure in the brain, so this will lead to a headache. If you notice in some over-the-counter headache medications, they'll have caffeine as an ingredient. What caffeine does is it constricts the blood vessels, so less blood flow is going to the brain, less pressure in the brain, and it will decrease the headache. Reflex tachycardia can also occur, just like we talked about the direct vasodilators of the antihypertensives. So if we dilate those veins too much, then the body reacts by increasing the heart rate. The caution at the bottom is to use gloves when applying paste or ointment or applying a patch. Can you think of why this would be? Why would you want to wear gloves when you're doing this? Well, it's pretty self-explanatory. If you're going to be putting a patch on your client or applying nitro paste onto their skin, then of course it can get onto your fingers and it could absorb into your skin, and then you would experience the effects of a nitrate also. So of course you want to obtain their blood pressure, and if you especially are giving IV nitrates, you want them to be on a cardiac monitor. When you administer IV nitrates, they have the greatest risk for severe hypotension because it's going directly into the bloodstream. This is something that I often did at Beaumont Hospital. If someone was experiencing severe angina or a heart attack, we would hang a bottle of IV nitro and we would titrate it until the person had no pain. So every 3 to 5 minutes I would ask, do you still have chest pain? Do you still have chest pain, or do you have no chest pain? And if they even said they had a smidge of chest pain, I would increase the dose, but you had to monitor them very closely. We want to educate our clients that alcohol is contraindicated with nitrates because both of them can cause vasodilation. And of course, if severe hypotension occurs, we want to withhold that nitrate. Sublingual nitroglycerin, so that's when they spray under their tongue or take a sublingual tab under the tongue, is short-acting and it's used to stop an acute attack that's in progress. So they have acute chest pain, they're going to spray it underneath their tongue. There are longer-acting nitrates, isosorbide, so they can take these orally as a pill or through a patch to decrease frequency and severity of angina episodes. What happens with nitrates, though, is that they can build a tolerance. So if someone kept a patch on for the full 24 hours every single day, then they would build up tolerance and the nitroglycerin wouldn't work as well. So what happens is that they usually need a 6 to 12 hour nitrate-free period. So it's usually taken off during the night. Can you think of why the patch would be applied during the day and then taken off at night and not the other way around? Well, what happens during the day is most people are awake, they're up, moving around, doing some kind of activity, and that's what happens with stable angina. This chest pain occurs with physical activity, physical exertion. We're increasing the workload of the heart. So we want to put that patch on during the time where they're most likely to be walking around and taxing the heart. I want you to take a look at the special considerations box on page 291 for some more information. All right, so beta blockers again, not only are they used for hypertension, but they are also used for angina. What they do is they decrease the cardiac workload, they decrease heart rate, and they decrease contractility. So they are often used for prophylactically for chronic angina. They're used to decrease the frequency and severity of attacks. Caution, though, is that you need to assess the apical pulse before administering it, especially if the client is also taking digoxin, since both drugs slow AV conduction through the heart, so that's the electrical activity of the heart, and it could lead to heart block if both of them are acting together. Calcium channel blockers, again, we already saw calcium channel blockers when we talked about hypertension, but they are also used for angina. Again, CCBs or calcium channel blockers are very similar to beta blockers in their side effect profile. They also reduce cardiac workload, they also reduce contractility, they dilate coronary arteries, they relax arterial smooth muscle, and which means that it brings more oxygen to the myocardium. Now, when we're talking about MI and thrombotic CVA, so these are medical emergencies. You may not be directly involved with administering these medications during these acute episodes, but you very well might be taking care of clients that received these kind of medications while they were experiencing an MI or stroke. So there are numerous drugs that are used to treat an MI, including analgesics, anticoagulants, antiplatelets, including aspirin, ACE inhibitors, and beta blockers. Thrombolytics, again, those are the big clot busters. They need to be administered within a certain time frame in order to save that tissue that is dying away. They should be administered within 3 hours for a thrombotic stroke and with 6 hours for an MI. So if you think about it, the heart and the brain are vital organs in our body, but the brain will trump the heart in terms of which is more vital. So that's why with the brain we have a less time frame, a less window to give the medication. Than the heart, we have a little bit more leeway. A good thing to remember is that time is muscle for MIs and time is brain for strokes. So again, the medication that I want you to kind of focus on to know a little bit more about is nitroglycerin. But as always, you are responsible to be familiar and to know all of the drug classes that we review in these different chapters. And that is the end for chapter 23.